While we're getting the slides up, just a quick straw poll. Before today, how many people had heard of SUDEP? Or let's show, how many hadn't heard of SUDEP? So quite a handful, including some of my patients. That's a worry. Okay, righto. How many people know what SUDEP stands for? Or how many don't know what it stands for? No, it's been explained now, so you all know. Okay, well, let's get started. Today we're going to talk about SUDEP, and we need to talk about it. I'm going to cover a number of areas reasonably quickly, and hopefully have some time for questions. Good. So we'll briefly introduce the topic. We'll look at some risk factors, clinical assessment. Some of it's quite medical, but it's pretty basic stuff. Look at the pathophysiology, what's the mechanism of SUDEP, and then we'll talk about how the hell can we stop it. And that's the biggest question. So, introduction. So SUDEP, what does it stand for? Sudden, S, unexpected, U, death in epilepsy. And so in that is, though, a number of assumptions. Sudden, well, sort of death's always sudden, but it's sudden and unexpected, not due to, say, another process you'd expect to be causing the death. It can be witnessed or unwitnessed. It doesn't have to be witnessed to be SUDEP. It's non-traumatic death, so it's not explained by, say, drowning or an injury, which can occur with seizures. And it's in a patient with epilepsy, a person with epilepsy. So you can't diagnose someone who hasn't got epilepsy, even though sudden death, a small proportion of them, probably are people who've had their first ever seizure and we didn't even know. And it should be in the absence of status epilepticus, one seizure after another, rolling along, as some of you might have experienced. And we define it in a number of ways, but essentially the post-mortem is crucial to knowing that it's SUDEP. But post-mortem works in a different way. It's not a positive diagnosis. It's saying, we can't find anything else, so maybe that's what it is. So the negative findings on a post-mortem are incredibly important in defining SUDEP. And so if someone's died, they have a post-mortem, they say, look, we can't find any problem with the heart, there's nothing else going on, and they've had a witness seizure, it's definite SUDEP. Now, if they've had a post-mortem and they find another cause, like they've, say, for example, got a major heart problem, they've got a clot in their vessel, then it's a non-SUDEP death. It can still happen in an epilepsy patient, but it's not SUDEP. And then if there's no post-mortem, this area is quite tricky. So, and a lot of the time we try and avoid post-mortems now. It's something we don't encourage really as doctors much, and we used to all the time. And a lot of patients' families don't want it. So the post-mortem often doesn't occur in SUDEP. But if there's a history of epilepsy, there's no competing cause for other obvious reasons why the patient's died, and they've had a seizure, then we define that as probable SUDEP. And when I'm going to talk about some incidents and numbers and things, and that's based on probable SUDEP and definite SUDEP. Does that make sense? So how common is SUDEP? Now, we're all epidemiologists now. There's questions about COVID. We're all experts on this, so I'm going to use terms that are quite medical, but we all know about incidents and things like that now because we're hearing it every day on the TV. And when we look at SUDEP, the first way to look at it is, okay, let's look at the population. Let's look at the whole group of people, so everyone. And the actual risk of SUDEP is relatively low when we look at a population. And so these are studies from USA, Australia, Ireland, Iceland. When you add them all up, the overall incidence per 100,000 people per year is about 0.81, about 1 per 100,000. So it's pretty uncommon. And when you look at sort of other population incidences things, you can see this is data from the Australian Bureau of Statistics. I picked a group that's relatively representative of SUDEP, younger adults. And as you see, SUDEP is the area in black. It should be purple, actually, but it's in black. And as you see, that's neurologic deaths, about half of which are SUDEP. So it's about 0.81 in Australia in 2017 to 2019. And sadly, that green line making up the bulk of it is accidents, trauma, but also suicide, which is about 15 times greater, disappointingly. But the trouble is that data, as you know with COVID, we've got to look at the at-risk groups. So you can't really apply this data to an individual. You need to actually apply it to individuals at risk, and that's patients with epilepsy. And so when we look at SUDEP, we've come up with this sort of different thing. Rather than most epidemiologists talking about 100,000 per year, we talk about patients with epilepsy and how many deaths occur or how many SUDEP cases occur per 1,000 patient years with epilepsy. So if you followed 1,000 patients for 1 year, how many occurred in that group. So if the incidence was 1 in 1,000 patients years, there'd be 1 death and 1,000 patients followed for 1 year. And again, looking at the various studies, I mean multiple studies, and this is summarised data. If you look at the patients just rolling up to the epilepsy clinic, then the rate is about 1 to 2 per 1,000 patient years. If you look at patients with drug-resistant epilepsy, that doubles. If you look at patients who've been worked up for surgery or failed surgery or having a vagal nerve stimulator, then the risk goes up alarmingly to up to nearly 10 per 1,000 patient years. So this is not uncommon, even though when you look at the population, it is uncommon. So it's quite a tricky thing to get your head around. And what are we talking about in WA? Well, look, the numbers are a bit rubbery about how much active epilepsy there is in the community. But by active epilepsy, I mean people still having seizures. And that's about 0.6% of the population. And so that means in WA in 2020, there's about 16,000 patients with active epilepsy. The seizures are continuing. And with a rate of about 1 in 1,000 patients per year, that means we expect about 16 patients. And that's probably what is happening right now in the community, and it's appalling. And we probably don't know about half of those, because the big problems with ascertainment of SUDEP is, for a start, the coroner doesn't quite even know that this exists. Some of the pathologists are only just really learning about it. This is, 21st century. And so I've actually seen death certificates that have been written that haven't mentioned SUDEP, yet I've spoken to the family. The patient had a seizure, they died. It's clearly SUDEP, but it's not on the death certificate. And we've audited that in WA, and it is improving, but it's still happening. So we're expecting about 16 patients a year in WA, and we're trying to reduce that, and that's why we're talking about it. So when does it occur? Well, this is based on quite a number of studies, but overall it's a young adult's disease. So it occurs between about the age of 15 and 50. And if you look at that graph, the vast majority are in the 20 to 30, 30 to 40, 40 to 50, 75% are in that group. But it does happen in kids, and the rate in kids is not much lower actually. So when you look at children under the age of 16, the rate's about 1 per 1,000 patient years, so not a lot different. So certainly being a child doesn't protect you from SUDEP. And then thinking about lifetime risk. So we're saying, okay, 1 per 1,000 patient years, but there's an ongoing lifetime risk. And so if you develop epilepsy in childhood, then you've got this ongoing risk that carries on, and it's cumulative. So over time, you risk it 1 per 1,000 every year. So if you start at the age of 1 and you live to 70, your risk of SUDEP goes up to 8%, so 8% lifetime risk of SUDEP. And if it's adult onset epilepsy at the age of 30 or something like that, the risk is about half that. And so the risk doesn't go away, it just continues. So there's a cumulative lifetime risk here that's high. What about other conditions? How does this compare? This is a study from 2010, so it's a bit old, but this is looking at US deaths from neurologic diseases. And as you can see, there's 2 skyscrapers on the left, dementia and stroke. You might say, okay, where's SUDEP? Well, it's buried down there. That's 3,000 or 2,500 deaths in US in 2010. So you might say, well, that's blown away by stroke and Alzheimer's. But then you look at lost years, because these are young adults and often healthy adults, and it's only second to stroke in terms of years of life lost, because these people are dying. If you look at quality of life as well, or quality of life years lost, these patients are often quite healthy, and if we can just control this age, they can be part of the workforce. So not only years lost, but it's money lost to the government, and we need to get that message across. So risk factors and clinical assessment. So when we look at people at risk of SUDEP, the way we try and figure it out, we get a patient who's died of SUDEP and they get a control. So that's someone with epilepsy who didn't die. And there's been multiple studies of this to look at what are the factors? Can we find what they are? And can we treat them or manage them or somehow figure it out? And there's multiple studies dating back well before the one in Sweden in 1999. But as you can see, not great numbers here. To be talking about something so serious as death related to a seizure, there's relatively few cases there. 299 if we group them all together from the major studies. But then in 2020, the Swedish doers, they do very well, like sort of brooding mystery dramas on SBS. They did a big study and literally doubled those numbers overnight in a massive study of 255 people. And that's what most of the things I'll talk to you about today is based on that study. But it's also looking at other studies as well. And so in that study, they had patients who died of SUDEP, in patients who had epilepsy who were controlled for age, gender, duration of epilepsy, and some other factors they controlled for, and just compared them. What did they have different? And so this is the data, and as you can see, TCS stands for tonic-clonic seizure. I'm sure you know that. And you see the tonic-clonic seizure in the last year, tonic-clonic seizures, 3 tonic-clonic seizures in the last year, nocturnal tonic-clonic seizures, they all sort of dominate in terms of risk. So if I just put the next slide on, the ones that are highlighted in red, they've got what's called an odds ratio. So that's like the odds. So 26 times greater risk of having SUDEP if you've had a tonic-clonic seizure in the last year. And similarly, very high odds ratios, you've had multiple tonic-clonic seizures over the last year, or nocturnal tonic-clonic seizures, but then also just not being seizure-free of any seizures is a risk factor. And they are sort of epilepsy variables, and there's a whole lot of other epilepsy variables that have been examined in these studies. Duration of epilepsy, that sort of makes sense. The longer you got it, the sort of ongoing risk continues. The so-called polytherapy paradox, so use of 3 or more drugs, and I'll come back to that, because you might say, I'm on 3 drugs, gee, that makes me at risk, but we'll talk about that a bit later. The type of drug used, they've looked at that, and the bottom line is various drugs have been implicated. There's no drug that's been clearly associated with SUDEP, so we'll probably put that aside. Greater than 50 seizures of any type per month, well, it's not great. Unsurprisingly, that's a risk. Primary generalised epilepsy, so that's the group of patients whose brain is otherwise normal, but they have tonic-clonic seizures, sometimes jerks, myoclonus, or absent seizures, and that was identified to be a risk in some studies. Not clear really in the bigger data and looking at the group's data. And intellectual impairment is another risk factor, and that's fairly consistent across studies. So that are the sort of epilepsy factors. What about the domestic and sort of comorbidity variables, those other conditions that might perhaps contribute? Living alone, and this is again from the Swedish study, significant greater risk. And sleeping alone, not sharing a bedroom. Not taking your meds is a risk factor. Substance abuse, illicit drug use, and alcohol, both consistently shown as being risk factors. And later today, I think we're talking a little bit about these things you can do to minimise the risk. So with all these factors, a number of epilepsy websites have generated checklists. And so you can go in there and, okay, tick the boxes, da-di-da-di-da, okay, I've got all these, I'm at risk of SUDEP, I need to do something about it. And they're probably vaguely helpful. But we were sort of thinking about this, we recognise there's some pretty famous people who've died of SUDEP. Flojo, remember the flowing hair and the nails? Amazing athlete. She died of SUDEP. And in fact, the death certificate doesn't say that, but that's what she died of. And she had a malformation of her brain and had 1 seizure prior, and then 2 years later, in 1998, she was found dead in bed. And she had 1 seizure ever that we know of. And Cameron, who a memorial has been placed, he had recently diagnosed epilepsy, diagnosed 11 months earlier, had 2 seizures in his sleep, he'd had very few seizures, and he had SUDEP. And so thinking about these checklists, okay, I've got to have this, this, and this, and that makes me at risk of SUDEP. There's an inherent problem with that, because you may be missing people like Cameron or Flojo who've only had 1 or 2 seizures. And we looked at this in patients who died in WA, and we applied these checklists to our patients who had died. And we had 36 patients who'd been seen at the epilepsy service who died of SUDEP over the last 2 decades, and fully 25% of them wouldn't have reached the sort of checklist kind of guideline to say, hey, there's a high risk of SUDEP here. So some of them died of the second seizure. Some of them had well-controlled epilepsy. And so, as you can see, Emma and I are there standing by the poster. This concept that we kind of have to direct, using a checklist, our SUDEP kind of discussions to these patients at risk, it's fine, but we're going to miss some. And that's not the right approach. We're going to have to talk to everyone. And we don't want people to have this false impression, oh, check the checklist, I've only got a score of 1, and they say 7's bad, so I'm okay. We don't want that to happen. And we've got to move away from that, I think. So coming back to risk assessment, just to drill down the bottom line, I'm not sure more kind of risks is actually helpful. And when you really look at the data, the 2 things I now do, and I didn't used to do this, the 2 things I look at is the patient having tonic-clonic seizures? And do they sleep alone? If that happens, I'm worried. Why am I worried? Because according to the Swedish data, that's got a 67 times odds ratio, so 67 times greater chance of dying of SUDEP. And so you just get two things, two simple questions, and that's all you need to say, okay, I need to talk to someone about this because I'm having seizures and I have them at night and I live alone. I've got to figure out a plan how to manage that. It's not quite as simple as it seems, as we'll come back to. So, pathophysiology. So that means what's the actual mechanism of this? And there's a number of sort of animal models of this, but the best data actually come out of video monitoring. And I know some of you in the room have had video EEG monitoring. We stop your meds, we want to see seizures, we're trying to figure them out, what's going on, can we operate, can we make your drugs work better? And sadly, during video monitoring, when they've got a number of centres, they found people have actually had SUDEP while they're having video EEG monitoring. And that's why we're so cautious. That's why Judy's there every day, sort of saying, okay, is the pulse oximeter on? And we've got all the safety things. If the family here, they're not there, we need someone else in the room, a nurse or whatever. And so what they did, they looked at a number of these near SUDEP, so people looked like they were going to die, but they were resuscitated, and people actually died, and looked at them and said, well, what actually happened? Because sometimes it's not very clear, when your patient's found dead and you're just not sure what the mechanism is. And what was shown compellingly for the 10 deaths where they had really good data, a tonic-clonic seizure was required, and immediately after the tonic-clonic seizure, there was a period of apnea, stopping breathing, and then there was a period where the heart slowed and stopped. So it seemed like the primary event was a tonic-clonic seizure, that switches off breathing, and then eventually switches off the heart. And that seems to be the mechanism based on that data. And there is a sheep model, amazingly enough, of this, and that's been demonstrated, a similar model in sheep. Now, humans are not the same as sheep, but that seems to be the if you like, the sequence of events that occurs. Brain seizures, stop breathing, heart stops. But there have been some where patients have had near SUDEP, where they've had a seizure and the heart's gone into unusual rhythm. And so it's not completely and utterly clear in all cases, but it looks like that's the most likely and most common scenario. So, talking SUDEP and preventing SUDEP, that's why we're here. Well, the first thing is we've got to start to educate. And Thanasis and I need to do this, but it's not just what every neurologist should know, it's what every doctor, but it was every person should know. And, not all neurologists know about SUDEP. That's a start. And most GPs don't know about SUDEP. I had one recently, and he heard about it the first time when a patient died. He was asking me about it. So I've never heard of this. Why haven't I heard of it, Nick? And it's because we're not talking about it, and we're not telling people. We're not educating medical students. But why are we talking about SUDEP as doctors to our patients? And there's been a number of studies. They're a bit old, these studies, and they may have changed a bit now, but they may not have. And so there's a study from Dundee in Scotland where in only 4% of cases of patients with epilepsy was it documented there was a discussion about SUDEP in the notes. So when we see a patient, as you do, we're writing away like crazy. If we talked about SUDEP, we would document in our notes, we discussed it, and that was only documented 4%, so 1 in 25 patients. And then there's a survey of UK neurologists, and again, it's a little bit older, it might have changed now, but they asked neurologists, they actually asked neurologists, how often do you talk about SUDEP with the patients? And the vast majority, either never or very few patients did ever discuss it. And so we're not talking about it, and that's a big problem. So what about Australia? There's a bit of data from Australia. So this is from Monash, Victoria. And again, they surveyed, this time they surveyed, instead of neurologists, surveyed patients. And they said, well, how much do you know about SUDEP? A bit like my first question, my straw poll. And only 14% in Melbourne, this is the city of epilepsy. This has got more epileptologists than any other city in the world. And in Monash, maybe down the road away from some of the bigger centres, only 14% of patients had actually heard of it. And these are patients interviewed, just random patients seen from the epilepsy clinic. 86% unaware of it. And then they said, well, how much would you want to know if you want to know? And that's quite interesting because not everyone wants to know about it. And so if we're going to take the approach everyone has to know about it, there's going to be a few people who didn't really want to know about it. But the vast majority want to know about it, and the vast majority want detailed information. They don't want to just hear it in passing. They want to know at least the basics and probably more. So coming back to Emma and I, when we talk about conversations with SUDEP, it looks like we're going to talk to everyone because we're going to miss 25% of patients based on our data, and that's been replicated elsewhere. 25% of patients are not really at high risk, so we've got to talk to every single person. And then I hear doctors say, I don't have time, the clinic's behind, da-di-da-di-da, it's a tricky conversation, what are we going to do about it? And I've been like that myself. Yes, some of my patients say they've never heard it from me, and they may not have. And those pressures do come on, but if we're not going to talk about death when we're talking about a disease, then we probably shouldn't be talking about anything, because at the end of the day, it's the most important. So what can we do? Well, let's start with my role, or neurologist, or the doctor. It doesn't have to be the neurologist, by the way, it can be the GP. So the simple things. Pick the right drug for the patient's epilepsy. And that's a kind of neurology thing, but it's really crucial. Polypharmacy I'll come back to, but the tiny add-ons is this thing that patients sort of sigh when I say, look, do you want to try another drug? And we know the more drugs you're on, the more side effects, and that's one of the greatest contributors to poor quality of life in epilepsy, is antibiotic side effects. But the patient's sitting there thinking, I don't want another drug, I'm so sleepy, I've got a tremor, I'm gaining weight, he's going to give me another drug, crikey. I'm thinking SUDEP. Maybe I'm not explaining it properly, because I'm thinking she's having tonic-clonic seizure at night, crikey, we've got to do something here. And there is a bit of, I call it treatment inertia. In America, they call it treatment complacency. Come on, you're having 1 or 2 seizures a month. That's not too bad. Let's plug on tonic-clonic seizure per month. Let's just leave it. And we've got to move away from that and talk about it. The trouble is that sometimes seizures are just impossible to treat. And many of you will know that the side effects are almost not worth the potential benefits, because you're in a constant fog saying, well, look, I'd rather take the risk of SUDEP. And we can talk about ways of minimising risk without me poisoning you with yet another drug. But when we talk about the other drug, there's this paradox, the polytherapy paradox, which means multiple drug paradox. So being on multiple drugs is probably a weak risk factor for SUDEP. But if you come along to the clinic and you say, oh, let's just wait and see and don't do anything, then you're going to be even greater risk of SUDEP. And this is shown by a study. I'll just fast forward this to one of these clever slides. So basically, some authors looked at all the treatment studies of patients with epilepsy where a new drug was being developed, and they're saying, okay, we're going to randomise you to either placebo, sugar tablet, or get the active drug. And they got this study together. It's about 20,000 patients, so big data. And they said, let's just see what happened. How many people had SUDEP within that time of the study who were treated with placebo, nothing, or got the extra add-on drug. So these patients having frequent seizures. You go to the doctor, he says, look, we've got the study going. Do you want to be part of the study? Say, yep, I want to be part of it. Okay, but you're not sure what you're going to get, placebo or active drug. And as you can see there, the people who got placebo were far more likely to die of SUDEP than people who got the active drug. And if you take the extra drug, you can reduce your risk significantly. And that, there's some drugs, perampanel's one. It actually may not be that great for stopping focal seizures, but it has a marked effect on tonic-clonic seizures. And so we've got to explain that as neurologists. This is why we're using it. You're having tonic-clonic seizures. We don't like the focal seizures, but we hate the tonic-clonic seizures. We need to figure out a way to stop them. And so that's why we're thinking about adding a drug on, because this data tells us that there's a good chance if that stops tonic-clonic seizures, it will save your life. So that kind of puts in perspective why we're constantly doing this. And look, it's just there's people who kind of get that nihilistic thing, and I sometimes get it as well. You sort of, a trialist or a nihilist. You keep trying drugs, or you give up. Say, look, we'll just stop them where we're at. But if someone's having tonic-clonic seizures, we've probably got to move away from that and say, look, let's try something else. And there's a lot of debate how to do that. Do you keep adding on, and then you're on 7, 8, 9 drugs, or do we substitute? And there's some data suggesting that substitution done in a judicious way may be a safe option to stop that constant escalation of the load of drugs that you're taking. So that's my role. Here's my other role, service responsiveness. I'm not going to get into politics, but we're woefully underdone in terms of number of doctors who are into epilepsy in the state and supporting. There's been a callous disregard in the state about epilepsy care, and that's not just Epilepsy WA, it goes all the way through to the clinics. And I don't know what to do about it. We talk and we have ministerials and we talk and nothing happens. And so, because that responsiveness that we need, so someone's having more tonic-clonic seizures, and they ring Judy and say, gee, I'm having more tonic-clonic seizures. I say, crikey, I've got 30 patients in the clinic this week. How am I going to do it? But we know if we don't respond, that patient is temporarily at greater risk of SUDEP. And so the responsiveness is really tricky to manage. And you say, go to ED, well, you all have that experience. It's a complete waste of time because they don't really understand. And so treatment responsiveness is an issue that's really tricky. And again, knowledge and those sort of things might help. But we won't get too much into politics. So what can you guys do? Well, yeah, think of this simple things. You're going to hear about, say, really simple stuff. Sleep, managing sleep, avoiding alcohol and drugs. And then monitoring devices. And Emma's going to talk about these, and I'm not going to get into too much, but you can monitor multiple things now reasonably simply. So heart rate, sweating, or sweating a bit in here, movement, so the EMG of movement of a seizure. These can be detected by various devices, and then alarms set off. And that's maybe the key to where we go forward with SUDEP. And they're all still in evolution, but this may be the future of reducing SUDEP. And then surgery. Pick your patients. If it's a surgical candidate, it should be looked at. Vagus stimulated dietary therapies. That's again sort of more advanced medical therapies. But the bottom line is, and that's why we're here today, is we've got to talk and we've got to educate. Because it allows you to make these decisions about your treatment or whatever. You kind of know where the information is coming from and why the decisions are being made or why you're just having these discussions. Because that's going to have the greatest chance of staying alive. And that's where we need Epilepsy WA to help. So that's a quick talk. I've gone a little over time. But any questions at all?